Joining me now is Dr. Malathi Srinivasan with Stanford Health Care to talk about the latest COVID-19 developments. Thanks for joining us. And let's start with this latest case of a potential reinfection. What does this say about immunity when it comes to COVID-19?
So this week, the University of Hong Kong reported that a 33-year-old man was actually reinfected with a different strain of coronavirus. And he was initially diagnosed with coronavirus with pretty mild symptoms several months ago and had documented evidence on repeat testing that he had cleared the infection. And then he'd gone to Spain, came back, was tested asymptomatically again, and he was found to have a second strain of coronavirus. So what this tells us is several things. First is that reinfection is possible, and like a lot of viruses, immunity to one strain of virus might not be protective against another strain in terms of getting infected, but usually what happens is after you have been infected and are reinfected, you have some degree of immunity so that the symptoms, typically the second time, are a lot more mild. And I think this is what we were seeing with this gentleman as well. So I don't think this is terrible, devastating news. Everyone was concerned that, if you get sick, can you get sick again? I think the answer is probably yes. But what we're hoping is what's true with many other viruses will be true with this, is that if you get sick a second time, you won't be as sick.
Does that mean that this is a different strain?
Oh, there's multiple strains of coronavirus and that are circulating, and there's some that are more severe. Some of the strains that are in Europe and a couple of the strains in New York, for instance, are more severe than some of the strains in other places. And it really depends on the number of spike proteins that are on the coronavirus shell in terms of how sticky is it and how easily can it enter your body once you are infected and infect you. So there are different strains of the virus, and what we're hoping is that immunity will last, and that after you've been infected, you'll still have some of the antibodies around, so you'll be able to mount a quicker, faster response, the way we see with most viral infections. So I think what we're seeing is not unsurprising. The early studies that were coming out of England and that were coming out of China, people really weren't able to document whether or not people had cleared an infection or were reinfected, or if they just had kind of a lingering viral infection and it was hidden somewhere and then just reactivated. So I think this settles the question of, can you be reinfected? I think the answer is yes. Does that mean that people are going to be hospitalized and die from a second infection? I think the jury is still out on that, but in my opinion, the answer is no. I think that what we will see, I hope, is that people will have just a mild infection the second time around that was not as severe as the first.
Talk treatment. The FDA recently granted emergency authorization to use convalescent plasma, but has there been enough research into this at this point?
And the research around convalescent plasma is still developing. On Sunday, the FDA approved emergency use authorization of convalescent plasma for use in patients who were hospitalized. Now, this was based on a study done by the Mayo Clinic with about 70,000 people from over 1,000 hospitals all around the United States. And you would think that that would actually solve the question, but the thing is, it wasn't a control study, it was an observational study. Their goal, based on early data, was to give people access to convalescent plasma in case it worked, and then also see how safe it was. But what we found is that overall, for all 70 patients, looking at 7-day mortality, so, were you alive or not after 7 days, there was no difference between people who had had convalescent plasma that had a lot of the immunoglobulins that we were hoping people would get versus people who had lower titers of convalescent plasma. Now, people might say, oh, what is convalescent plasma? What that is blood taken from people who have recovered from COVID, and not the component that has all the cells like your red cells and your white cells, but rather the clear portion that has all of your immunoglobulins. So convalescent plasma is plasma from people who have recovered from COVID and who have antibodies against the COVID-19 virus. And so the thought is that you would get passive immunity And if they were able to fight off the infection, maybe their immunoglobulins would help you fight off the infection. So overall, there was no difference in the study. But here's the kicker. When they went back and looked at all of the patients who had gotten convalescent plasma, what they found was that if you were younger, so less than 80, if you were less sick, so not on a ventilator, and if you got the treatment earlier within 3 days, the mortality was different if people got the higher immunoglobulin versus the lower immunoglobulin titer convalescent plasma. And so the mortality rate was 11% versus 6%. Now, you would think, oh, this sounds like really good news. But much like the data with hydroxychloroquine and azithromycin, it could just be because people are recovering and they're younger and not as sick. So Stanford's actually doing a very exciting study called C3PO that it will hopefully answer this question a lot better.
Yeah, so Stanford did recently start a study on convalescent plasma. What are the findings on that so far? I know it's early.
Well, we've just enrolled our first patient, and it's actually a very exciting study. So this should settle the question as to whether convalescent plasma works or not. What it's doing is enrolling patients into a study to see if convalescent plasma works and randomizing 600 people to either getting no plasma or getting convalescent plasma. And we're just using the high titer plasma because, the lower titer plasma doesn't seem to have had an effect based on the Mayo clinical study. So, we've enrolled our first patient. It's very early. Of course, we're not going to know for several months, but I think that this will settle the question as to whether or not it works or not.
So we're finding out a lot more about how prone somebody is to getting the coronavirus. Have we been hearing anything recent about weight and what role that might play?
So, Anne, we've known for a while that obesity, having a lot of fats, and there's different ways of grading it, is a significant risk factor for dying from coronavirus. And in fact, this was shown in a study of about 17 million people from the National Health Service in the United Kingdom, where they had looked at people who had died or not died from coronavirus after being infected. And with thousands of deaths, they were able to show that weight made a difference, as did a bunch of other things, different ethnicities and age. Very importantly, age being about 10 times, if you're greater than 80, giving you over 10 times the risk of death from coronavirus. Now, this hadn't been done in the United States until recently. And what we found is that a study that just came out from Kaiser with several thousand patients, so 7,000 patients who had been infected with coronavirus, and 200 of them had passed away. Taking a look at the characteristics of people who had died versus not died, what they found is that if you were morbidly obese, meaning that you had a body mass index of greater than 40, or if you had even more extreme obesity with a body mass index of more than 45, you had between 2 to 4 times the likelihood of death compared to someone who was more normal weight. And this was especially true if you were a man. So we've known that male being a man or having a high weight or having an organ transplant all predispose people to death from coronavirus. And the a Kaiser study showed this as well. The surprising thing about the Kaiser study was actually that ethnicity and race did not make a difference. And we've been hearing a lot in the news about the fact that people who are Hispanic or African American are dying in greater proportions to the non-Hispanic population. And this study actually had shown that if in the Kaiser system, which is a capitated system where everybody has equal access, people who were African American or Hispanic had about the same mortality as everybody else in this 200 people who had passed away of the
Okay.
7,000 people who were infected.
Interesting. Interesting. All right. Anything else? No, any other late breaking info on the coronavirus?
No, I think that we're all just waiting for a vaccine to emerge that's going to be proven to work. And I think that's going to take a little while because hopefully we're bending the curve well. And so, getting people to enroll in these trials is a little bit challenging, as you can imagine. So the vaccination studies are going to take a little while to show efficacy.
Interesting. All right. Well, Dr. Malathi Srinivasan with Stanford Health Care, thanks so much for that.
Well, thank you for having me today.